Today we are going to talk about raised intracranial pressure. Under this topic we will discuss normal mechanisms of maintaining intracranial pressure, causes for raising intracranial pressure and symptoms of raised intracranial pressure. First, let's look at what is the intracranial pressure. Intracranial pressure is the pressure within the craniospinal compartment. Cranium means the skull. Skull is the bone framework which encloses your brain. Beneath the skull there is the brain. The compartment under the skull is the cranial compartment. That cranial compartment is continued with the spinal compartment, and the cranial and spinal compartment together is a closed system. This system comprises a fixed volume of neural tissue, blood, and cerebrospinal fluid. The neural tissues, blood and the cerebrospinal fluid exerts a pressure on the skull. Skull is a bony, rigid structure. So the pressure exerted by the blood, CSF, and the brain tissue turned back and exerted on the blood, CSF, brain tissue. Beneath the skull there is the closed cranial compartment. In cranial compartment brain is located and it takes 80% of the compartment space. The volume of the brain is 1,400 milliliters. In the cranial compartment 10% of the compartment space is taken by the blood. The volume of the blood in cranial compartment is 75 to 100 milliliters. In the cranial compartment, another 10% is occupied by the cerebrospinal fluid. The volume of the cerebrospinal fluid in the brain is 75 to 100 milliliters. Now let's jump into cerebral dynamics. Cerebral dynamics means the characteristics of blood and CSF flow in the brain. Let's first look at the blood flow in the brain. Brain receives the blood from the internal carotid arteries and the vertebral arteries. The pressure inside the arteries is around 90 millimeters of mercury. Brain drain its blood to internal jugular veins. Pressure inside those veins is around 3 millimeters of mercury. Brain receives 750 milliliter of blood per minute. That's 15% of the cardiac output. Then let's move on to cerebrospinal fluid dynamics. First let's look at how the CSF is secreted and absorbed. CSF is secreted by choroid plexus located in lateral, third and fourth brain ventricles. Usually 20 milliliters of CSF secreted per hour from those ventricles. Then the CSF reach the fourth ventricle. Then majority of the CSF is drained to the subarachnoid space, system of the brain and to neural tube. A little amount is drained into facial lymphatics. Then the CSF is absorbed to the dural sinuses via arachnoid villi. Arachnoid villi are small protrusions of the arachnoid mater into the outer membrane of the dura mater, in other words, to the dural sinuses located in dura mater. Then from the dural sinuses CSF is drained to the jugular venous system. Now let's see what happens when the intracranial pressure fluctuates. This is explained by Monro-Kelly hypothesis. It tells that the sum of the volumes of brain tissues, CSF, and intracranial blood is constant. An increase in one should cause a decrease in one or both of the remaining two. As the skull is a rigid structure, the pressure inside the skull is a constant. So when the pressure goes up inside the skull, the volume of the brain or CSF or blood is reduced to compensate the increased pressure. As you can see in this equation, intracranial pressure is the sum of pressures exerted by brain, blood and CSF. If pressure of one component goes up, the volume of other compartments reduces to compensate the increased pressure. Now let's discuss the causes for increase of intracranial pressure. They are space-occupying lesions in the brain, cerebral edema, obstruction to the CSF flow and CSF absorption, increased blood volume in the brain. Space-occupying lesions in the brain are masses occurring in the brain. Hematoma, abscesses, tumors are some of the masses occurring in brain. Cerebral edema can occur due to traumatic brain injury, viral or inflammatory encephalitis, hypoxic ischemic encephalopathy, hepatic encephalopathy, stroke. Obstruction to the CSF flow occurs from rare cancer called choroid plexus papilloma. Increased blood volume in the brain occurs due to vascular malformation and cerebral venous thrombosis. Now let's move on to compensatory mechanisms of increased intracranial pressure. So when the intracranial pressure is increased, initially the CSF production decreases and absorption of CSF increases. More CSF is displaced to subarachnoid space. So the increased pressure is compensated by reducing CSF amount in the brain. If the compensation by reducing CSF is not enough, then the blood amount in the brain is altered by vasodilation of vessels, and increasing the venous drainage to the dural venous sinuses. If both previously mentioned ways failed, then the brain dural spaces are distended to compensate the pressure. If all of these methods fails, there can be fatal effects such as brain herniation due to increased intracranial pressure. This is the normal state of the cranial compartment. The intracranial pressure is normal. In here you can see there is a space-occupying mass. So the mass is taking some of the volume of the cranial compartment. So the pressure rises. To compensate the raised intracranial pressure, CSF volume and blood volume is decreased. In here the increased pressure compensation range is exceeded. The maximum amount of CSF and venous blood that can be reduced, has reduced to compensate the raised pressure. But still the intracranial pressure is high. There can be brain herniation due to pressure exerted on brain tissues. This state is called the decompensate state. This is a dangerous condition. Under the effects of the increased intracranial pressure, let's first look at what will happen in the brain when the intracranial pressure rises. When the intracranial pressure rises, the cerebral perfusion decreases. Reduced cerebral perfusion stimulates further swelling of brain. Because of the swelling, brain tissues shifts through the openings in the rigid dura. This is known as brain herniations. Now let's see what are the types of brain herniations. They are tonsillar herniation, uncal herniation, transtentorial herniation, transcalvarial herniation, subfalcine herniation. Among these, the most common herniations are tonsillar and uncal herniation. In the tonsillar herniation, the tonsils of the cerebellum herniate through the foramen magnum into the upper spinal canal, compressing the medulla. Clinically, this may result in cardiorespiratory impairment, hypertension, high pulse pressure, Cheyne-Stokes respiration, neurogenic hyperventilation, impaired consciousness, and finally death. In the uncal herniation, uncus of temporal lobe herniates between rostral brain stem and tentorial edge into the posterior fossa, resulting in a clinical syndrome of progressively impaired consciousness, dilated ipsilateral pupil, and contralateral hemiplegia. Then let's see what are the effects of increased intracranial pressure. Let's first look at the vital signs of raised intracranial pressure. The heart rate and the respiratory rate reduces and the systolic blood pressure increases. This three signs altogether called Cushing triad. There can be pupillary constriction followed by unilateral pupillary dilation. Cardiac arrhythmias also can occur. Pupillar edema occurs when the optic nerve located in the back of the eye becomes swollen. This may cause visual disturbances, headaches, nausea. Then let's look what are the symptoms of increased intracranial pressure: vomiting, headache, blurred vision, sleeping and lack of energy, feeling less alert, weakness with moving or talking are the symptoms of increased intracranial pressure. Blurred vision occurs due to pupilledema. Increased intracranial pressure is a dangerous condition and most of the time it is considered as a medical emergency. So we hope you guys learned something from our video. We will deliver more videos in the near future. Subscribe us to get the notifications of new releases.